Dr. Higgins. I'm with Tidewater Orthopaedics. We're going to talk tonight about treating hip and knee pain, two subjects that are very near and dear to my heart because I am a hip and knee replacement specialist. That's what I focus almost 100% of my practice on. So a quick preview of our topics tonight. We're going to talk about my group, Tidewater Orthopaedics. We're going to cover the orthopedic hospital at Sentara CarePlex. I'm going to go over different types of arthritis. We'll talk about non-operative treatments for arthritis. And I'm going to talk about some new things, or newer things for hip and knee replacement. That's the direct anterior hip, or Jiffy hip, and computer-navigated and robotic-assisted knee replacement. And hopefully those topics will generate a bunch of questions, which I'll be happy to answer at the end of the talk. So this is my group, Tidewater Orthopaedics. Our tagline is the specialist group. We have 9 orthopedic surgeons and 4 PAs, soon to be 10 orthopedic surgeons. We have a new surgeon joining us in August, Dr. Robert Mason, who's a hand and upper extremity specialist. Our philosophy is the subspecialty model, which Melissa was mentioning. Our philosophy is that if you focus in on one area and do a lot of one thing, really specialize on it, you're going to be better than if you're trying to do everything in orthopedics. So we have surgeons that specialize in hip and knee replacement, that's me. We have sports medicine specialists, shoulder specialists, hand and wrist specialists, foot and ankle, and spine specialists. So we have pretty much all these subspecialties covered, except for pediatrics. We are an independent practice, and we're the sole providers at the orthopedic hospital at Sentara CarePlex. The orthopedic hospital at Sentara CarePlex is a pretty well-kept secret in the area, but this is a wonderful facility. This is the first dedicated orthopedic hospital in Virginia. It opened in July of 2010. This is a wing that was added on to Sentara CarePlex solely dedicated to orthopedics. This represents a $30 million investment in orthopedic care for citizens of Tidewater. We have inpatient and outpatient orthopedic surgery centers. And this is managed by Tidewater Orthopaedics along with Sentara, so it's a co-venture. At the orthopedic hospital, we have 2 inpatient operating rooms. We have 20 inpatient beds. We have our own separate inpatient physical therapy. For the outpatient surgery center, we have 2 operating rooms, that's soon to be 3. We do outpatient hip and knee replacement for patients that are healthy enough. So that is a reality. What I really like about the orthopedic hospital is that we have kind of the best of both worlds. We have boutique care with large medical center expertise. On the expertise side, all of our surgeons are subspecialty trained. And all the nurses and LPNs that work in the hospital are certified in orthopedics. So there's a very single focus on taking care of orthopedic problems in this orthopedic tower. You have high volume experience. We do over 800 joint placements a year. We have dedicated joint replacement and spine centers. And that's probably what you'd expect from any hospital, right? You know, to be specialized and do a good job. What's really unique about the orthopedic hospital and different from other places is that we have our own facility, and it allows us to do things with our patients that are different. I think from a patient standpoint, the biggest difference is we're able to take any sort of infected case and not have it in our operating room. So if someone's going to have their hip or knee replaced, if you go to the orthopedic hospital, you don't have to worry about following a dirty case, like maybe someone had an amputation or a colon surgery. Having a hip or knee replacement following a quote-unquote dirty case is one way to get an infection. That's been shown to be a risk factor. And if you spend the night in the hospital, the nurses and care partners looking after you aren't going to be going from your room to a room with somebody who has an infection. There's no infected cases, no infected patients on our floor. And that's a huge difference. We have the healthy patient model, which I'm going to go into. So this healthy patient model is something that I've been working on for the past decade, since we opened the hospital. And basically, what it is if you're going to have your hip or knee replaced, you're not sick. If you're sick, we've tuned you up, we've gotten you in good shape. This isn't like an emergency, it's a planned surgery. So we're not going to pretend that you're sick. We're not going to try and keep you in the hospital for days on end and then send you to a nursing home. Our focus is get you up and get you moving minimize your interaction with the hospital, get you home, don't keep you housebound. It's okay to go out, start outpatient therapy sooner. In doing this, actually, there's less complications. There's less infections, there's less blood clots, because people are getting up and moving right away. And this, the opposite would be what I call the sick patient model, which is what's more traditional, where you come in the hospital and you have a longer stay. If you have a hip or knee replacement, you might be in for 3 or 4 days. And instead of going home, you're going to go to a nursing home or a rehab center to do therapy there. Slower mobilization, you're not going to get up as soon. Well, to some people that sounds good. There's actually higher complication rates. The hospital is an excellent place to get sick, and it's an excellent place to get a really bad infection. So if you're healthy and you're having an elective surgery, you don't want to hang out in the hospital any longer than you need to. That's why we do the healthy patient model. So, how do we achieve that? Well, there's a lot of things that go into it. We have a very strong emphasis on preoperative education for our patients. We have classes every week for patients having hip and knee replacement to learn what to expect before, during, and after the surgery. If patients would benefit from preoperative physical therapy, we have those programs set up. We have rapid mobilization. We get patients up the same day of surgery to get you moving right away. We try to minimize the hospital stay. And we try to start the outpatient therapy sooner instead of keeping patients housebound after surgery. If you're mobile enough, we'll get you in outpatient therapy anywhere from 3 to 10 days after surgery. Another big part of the healthy patient model is controlling pain, because depending on how you do these surgeries, there can be a lot of pain afterwards. Multimodal pain control is something that I've been doing for many years, and this works really well. The theory behind this is that you're going to have a surgery and it's going to hurt, so I will treat your pain before it starts. And I'm not just treating it with narcotics. We're using medicine that works on all the different pain receptors, from your skin to your spinal cord to your brain, as well as local and regional blocks. And by doing this, we're able to decrease pain and also decrease narcotic use. If you have to use a lot of pain medicine, a lot of narcotic pain medicine, there's a lot of side effects: confusion, constipation, nausea. And if you have those things, you're not going to be leaving the hospital very soon. So multimodal pain control is a big part of how we get people up and moving quickly. I have programs for my patients to make sure that there isn't any modifiable risk factors for infection or complications after surgery. There are things that we can do to make patients healthier, and I've kind of institutionalized these in my practice. So all patients are screened for MRSA. MRSA is a type of bacteria that can cause very serious infections, and it's in the community. Some people have it on their skin. And if you're a carrier for it, that puts you at very high risk for developing a very serious infection with a hip or knee replacement. So I screen all my patients for this. If you're a carrier, you're going to get treated for it before you come in and have your surgery. Anemia is another one that, if you're anemic, that raises the risk of complications after surgery. So I screen for anemia and treat that. Malnutrition and poorly controlled diabetes are 2 others. So there's things we can do to tune people up before surgery to make it a safer procedure. Our operative times, our blood transfusion rates, our complication of care ratios, as a result, are amongst the best, not just in Virginia, but in the United States. And that's not just my opinion. We've won several awards. We've been given the Health Grades Joint Replacement Excellence Award the last 2 years. We've been given the Patient Choice Award for customer service from 2012 through currently. We just got the 2017 award. We've been recognized by Anthem, Blue Cross and Blue Shield as a Center of Distinction. And Becker's Hospital Review recognized the Orthopaedic Hospital as one of 100 hospitals nationwide with great orthopedic programs. So that's the Orthopaedic Hospital. Now I'm going to talk about different types of arthritis. When it comes to arthritis, there's 2 main types of arthritis. There's osteoarthritis and rheumatoid arthritis. Now most people that have arthritis have osteoarthritis. This is by far and away the most common type of arthritis. It's a degenerative disease that causes the cartilage in your joint to wear away and break down. And that's what arthritis is. A lot of people, arthritis gets thrown around, the term, but a lot of times, people just aren't quite sure what that is. arthritis is when the cartilage in your joint starts to break down and wear away. And as that cartilage breaks down and wears away, bone becomes exposed, so you have bone rubbing on bone, which is painful. When bone sees more force, when bone is touching bone, it makes more bone. So you get bone spurs and scar tissue, and the joints start to get stiff. That's what arthritis is. Osteoarthritis is a leading cause of disability worldwide, according to the American Academy of Orthopedic Surgeons, and it's estimated that almost half of all people will be affected with knee arthritis in their lifetimes. So it's very common. Rheumatoid arthritis is not nearly as common. It really affects only about 1.3 million Americans. And rheumatoid arthritis is an inflammatory type of arthritis where your immune system attacks your joints. And your immune system attacking your joints causes the cartilage to break down and degrade and leads to arthritis. So what are the symptoms of arthritis? Well, the most common symptom of arthritis is pain or stiffness in the joint. You can have swelling with arthritis. The joint may be warm or hot to touch. As it progresses, you start to limp. And the knee can cause deformities where you can become very bow-legged or knock-kneed. Those are the common symptoms of arthritis. But not all joint pain is caused by arthritis. So if you're having, hip or knee pain, you should really see an orthopedic professional, because there's a lot of things that cause joint pain that aren't arthritis and are generally easier to treat. If you do see an orthopedic professional, they're going to want to get a history and they're going to want to examine your joint. But when it comes to diagnosing arthritis, 95% of the time, all we really need is an x-ray. So here's an x-ray of two hips. On the left, we have a healthy hip, and you can see that there's plenty of space between the ball and socket of this hip. And that is not empty space. That's the articular cartilage in the joint. So that's a healthy joint. On the right-hand side, this is an arthritic hip. And you can see that clear space is gone. That's what they call bone-on-bone arthritis. There's whitening or hardening of the bone because it's seeing more pressure and you're starting to develop bone spurs on the, above and below the hip joint. That's a very arthritic hip. For knees, same thing. On the right-hand side, we have a healthy knee with plenty of articular cartilage, clear space, very little, if any, bone spurs. And on the right-hand side, a very arthritic knee, again, with bone-on-bone arthritis and lots of bone spurs. So what are some non-operative treatments for arthritis? Well, these are all things that are very effective if you have mild or moderate arthritis. So the first one is weight loss. Easier said than done. If you are overweight, losing some weight can help with arthritis. For your hips and knees, every pound you lose will take 3 pounds of pressure off your hip and knee when you're walking. So that can have an impact. If you have x-rays that look like the ones we were just looking like, that's probably not really good. But weight loss can be helpful. Physical therapy and low-impact exercise can be very helpful for mild and moderate arthritis. The saying, motion is lotion. Doing a consistent exercise program can be very, very helpful. The key and the reason that I put exercise with therapy is that if you did go to therapy and it helps, you need to continue those exercises to continue to have the benefit. And generally speaking, with arthritis, lower impact exercise is much better. So things like walking or swimming, riding a stationary bike, weightlifting, those are all good examples of relatively low impact exercises. Running, elliptical machines are higher impact and probably are not going to be well tolerated with more advanced arthritis. There are braces that can help, particularly for knee arthritis in its mild or moderate forms. There's braces that'll push on your knee and take the pressure off the arthritic side and put more pressure on the less arthritic side. That tends to be most effective in men who are in their 40s or 50s and have a muscular frame that will hold the brace. Unfortunately for women, the braces don't seem to work as well. There are some women they work well for, but a lot of times there's difficulty keeping them centered around the knee. They tend to slide down the leg. Beyond that, there's medicine. First place to start would be Tylenol, which is a pain reliever, but not an anti-inflammatory. Tylenol can be very effective for pain. The next step up from that would be an anti-inflammatory or an NSAID. So that's things like ibuprofen or Aleve. And that can help with arthritis by relieving the inflammation. There's cortisone injections, which I'm sure everyone's heard of, and they do work very well for arthritis. The reason a cortisone shot is so effective for arthritis is that you're getting a very, very strong anti-inflammatory, a steroidal anti-inflammatory, and you're getting a mega dose of it right where you need it. So if it's in your hip or your knee, they tend to work well for that reason. You can never get that much medicine in your hip or knee by pill. There are hyaluronic acid injections, gel shots, or sometimes they're called rooster cone shots. These can be very effective for knee arthritis that's mild or moderate. There's a growing body of literature showing their effectiveness for advanced arthritis in the knee is not very good. And then the next thing that seems to be on the horizon is stem cell injections for arthritis. And I think that someday we're going to crack the code on how to make these stem cells work. Currently, we don't have much scientific evidence that stem cells are effective for arthritis. I think we'll get there, but currently they're not covered by insurance, and there's not a bunch of literature showing that they're effective. So when should someone consider a joint replacement? Well, joint replacement surgery is an elective quality of life procedure. So the decision to have a hip or knee replacement is a quality of life decision. Things that patients tell me when they're ready to have a hip or knee replacement are things like they can't keep up with their spouse or their friends, their hobbies or their pastimes are becoming too painful, they can't sleep at night, that's a big one. You know, if you let it go far enough, it'll get to where you can't sleep, and that'll usually get even the most stubborn patient who doesn't want to have surgery to think it over. So that leads us to total hip replacement. And total hip replacement is amongst the most successful surgical procedures performed today. And that's because it does the things you'd want a surgery to do. It restores patients' quality of life. It's very effective at getting patients back to an active lifestyle. It's effective at giving good pain relief. Complications are rare, they're not unheard of, but they're rare. And it's cost effective. It's not an inexpensive surgery, but if you look at the cost of replacing someone's hip compared to the cost of treating someone without a hip replacement who has severe arthritis, it's more expensive to take care of that patient for the rest of their life than to fix them and get them up on their feet and move them. Currently, about 250,000 hip replacements are done each year in the United States, and that's an increasing number each year as our population gets older. Hip replacement has a proven track record. When we look at patients that had their hips replaced 25 years ago, 80 to 85% are still functioning well. Now, when those patients had their hips replaced, they were told that they'd probably last 10 or 12 years, so we're doing better than we thought. These numbers, in terms of survivorship, are based on older implant designs and older materials. And some of the materials, particularly the plastic component of a hip and knee replacement, is manufactured differently now, and the wear rates are about 1/8 of the old stuff that's still working 25 years down the line. So I think to anticipate 20 to 25 years out of a joint replacement is not unrealistic. So we'll get into the anatomy of the hip. The hip is a ball and socket joint. The ball is the top of your femur, that's the femoral head, and the socket is the inside your pelvis, or the acetabulum. The ball and socket of your hip are covered with articular cartilage, and that's what allows joints to glide and move nice and smoothly. That's what starts to break down as your hip becomes arthritic. What are the symptoms of hip arthritis? Well, the most common symptom is pain, and the most common location of that pain is your groin. Most people don't think of their hip as being in the groin, but your hip is actually, if you look at a skeleton, it's in the front of your pelvis, it's in the groin. So most patients with hip arthritis have quite a bit of groin pain. Some patients have a lot of buttock pain. Hip arthritis sometimes will mimic low back pain or low back problems. Anterior lateral thigh pain is common. Some patients will present with severe arthritis in their hip and only have pain in the front of their knee. They have referred pain in their knee and they're not really sensing any pain in their hip. So those are the common symptoms of hip arthritis. And of course, with hip arthritis, there's stiffness and weakness. Things like getting in and out of the car, putting your shoes and socks on, become more and more challenging. So what is a hip replacement composed of? Well, this is the implant that we use for a hip replacement. These are the basic components. There is a shell right here, and this is typically made of titanium. And these implants can be fixed to the bone with cement, or they can be press fit. Most of the implants in North America are press fit, and that means that the metal has a three-dimensional component to it, or a two-dimensional component to it, that the bone grows into. It's not fixed with cement. So typically this socket is three-dimensional metal that the bone grows into. A plastic liner goes into that socket. Now the socket goes into the acetabulum after all the worn out cartilage is reamed away, and these come in all different sizes. So it's not like there's just one size and we gotta make it fit everyone. These are modular components. They come in a rainbow of sizes to fit almost any person. On the femoral side, there's a stem that goes into the top of your femur. And the purpose of that stem is to give us some place to put the ball. So that's the anchor in your leg for the head ball. And again, the femur has porous metal on it that your body grows into, so it's a biologic fixation. And on top of that goes a cobalt chrome or a ceramic head ball. So those are the components that make up a hip replacement. So hip replacements have been being performed since the 1960s. And like everything else, as time goes on, things get innovated and get better and better. I think the most recent, greatest innovation in hip replacement has been the direct anterior approach, or use of the direct anterior approach to do a hip replacement. Now when I say approach, what that means is, how do you get into the hip? Because if you're going to do the surgery, these implants are pretty universal. There's different types, but we're not using a special implant for one way versus the other. But how do you get down into the hip? How do you get into the joint to do the surgery? That's what approach means. So in order to explain what's unique about the direct anterior approach, I need to first explain how most hip replacements are done, and that's through a posterior or a lateral approach. And in this approach, muscles are split and cut to get into the hip. And the surgery is then done, and on the way out, everything is repaired. But that causes weakness and pain, and it causes more time on a walker or a cane, more time in physical therapy, because it's more invasive surgery. There may also be a higher risk of dislocation with the posterior approach. So to give you some idea, I'll just kind of quickly walk you through what the posterior approach would entail. So the surgery is done with the patient lying on their side, and that's what this picture shows. An incision is made over the lateral part of your thigh. And once the skin is dissected, the next thing that's cut is the IT band and your gluteus maximus. That muscle split. And beneath that, 4 muscles are cut off the back of the femur to get into the hip joint. Now you're down to the capsule, and the capsule's open, and now you do the surgery. But that's the approach. That's how you get in. It's fairly invasive. With the anterior approach, muscles are not cut. That is, in a nutshell, that's the big difference. So the surgery is done with the patient lying flat on their back, and the incision's on the front of the hip. And instead of cutting muscles, because your hip is actually in the front of your pelvis, the muscles can be moved medially and laterally, giving exposure to the joint. So just to kind of walk you through what this approach entails, it's an incision. This is a schematic. It's usually about a 3 or 4 inch incision on the front of the thigh. And below the skin, these muscles are then, they're not cut. One's retracted medially, one's retracted laterally, and right below that is the hip joint. So the capsule's open, and now you're in the hip. This approach, the anterior approach, is not a new way of getting into the hip. This approach has been around for about 120 years. What's new is that we have new techniques and new equipment, new tables that allow us to use this minimally invasive approach to do a hip replacement. So this is the table I use. It's called the HANA table. And it looks like a torture device, doesn't it? It does. But it's a wonderful piece of equipment. This allows me to do a hip replacement through the anterior approach. And the big thing about it is that as you look here, the patient's legs are on these spars. So once the dissection is done, I'm able to drop the leg down to the floor, which brings the femur up into the incision to get that stem in. That's what's been the hard part before. And you can do it through a much smaller incision. So one of the things that are nice about the anterior approach is that because the patient's flat on their back, it's very easy to use C-arm, which is like a portable x-ray, to get images, spot images, as you move through the procedure. So it kind of increases your precision in terms of implant placement and leg length, because not only am I using anatomic landmarks, but I can get the real answer with an x-ray in about 5 seconds. You can get an x-ray with a traditional approach to the hip, but that entails bringing in an x-ray machine, taking the x-ray, developing it, waiting for it. You're not going to get many x-rays that way. So that's another thing that's really nice about the anterior approach. The surgery takes anywhere from an hour to an hour and a half, so it's a relatively quick procedure. So this is a patient, just to show you what the results are like. This is a patient, 2-week follow-up from hip replacement surgery, and see if you can tell which hip he had replaced. Anyone have any idea which side? Left. That was a trick question. He had both hips replaced.
At the same time?
At the same time, yeah. Wow. So this guy was in his mid-50s, very healthy, bad arthritis, working, perfect candidate for both hips. So maybe you think he's too healthy, too young. This is a 92-year-old woman 2 weeks after her hip replacement. So she's not lighting the world on fire, but not bad. Not bad. Another big advantage of the anterior approach, and I touched on this earlier, is that you don't have hip dislocation precautions. Because less of the normal tissue around your hip is violated with this procedure, there's more intrinsic stability right off the bat. So with the traditional approach, there's hip dislocation precautions, which really make life difficult. You're not supposed to bend more than 90 degrees at the waist. You're not supposed to sit in low chairs. You need help putting your shoes and socks on. A lot of paranoia. And with the anterior approach, you don't have these. So it makes recovery much more pleasant. After surgery, 1 night in the hospital for most patients. Some people go home the same day. We get you up walking the same day of surgery. Therapy starts that day, more therapy the next day. Patients progress from a walker to a cane to nothing. Most patients are walking with a cane or nothing within 2 weeks. In terms of driving, it's usually about 2 or 3 weeks before patients are comfortable driving. In terms of returning to low impact activities, golfing, swimming are allowed anywhere from 1 to 2 months after surgery. I generally recommend patients don't go back to high impact things like running, playing basketball. When I say heavy manual labor, I mean, breaking rocks and hauling bricks and things like that. You can do yard work. So that's hip replacement. I'm going to touch on knee replacement real quick and then we'll take your questions. So knee replacement, just like hip replacement, one of the most successful surgical procedures performed because it works. It takes care of pain, gets people back on their feet. Complications are relatively rare, and it is cost-effective treatment for knee arthritis. Just like a hip replacement. Knee replacement surgery, though, is much more common. I said there was about 250,000 hip replacements each year in the United States. That number for knee replacement is 650,000, and that number is going up quicker than hip replacement numbers. So much more knee arthritis out there than hip arthritis. Just like hip replacement, knee replacement has a proven track record. When we look at patients 20 years out, about 80 to 85% are still functioning well. So the survivorship's not quite as high as hips, but it's pretty close. And again, these numbers are based on older implant designs and older materials, namely the plastic, which the newer plastic we believe is going to last a lot longer. Knee anatomy is a little bit interesting. Most people think of their knee as a hinge, but it really is not. Your knee has very complex anatomy. When we bend our knee, it actually rocks and rolls. Flexion and extension of the knee is a combination of sliding, rolling, and rotating. And that makes knee replacement difficult because it's hard to recreate that motion. When you think about the way your knee moves, most of it is done by the end of your femur, the femoral condyles. It's this portion here that's kind of shaped like a rocking chair. And that's covered with articular cartilage, just like the ball and socket in your hip, and that's what wears out in knee arthritis. When that wears out, it's time for a knee replacement. So there's two basic types of knee replacement. There's total knee replacement and partial knee replacement. Total knee replacement is the gold standard treatment for advanced arthritis of the knee. With a total knee replacement, all the cartilage in your knee is replaced. So there's no cartilage left. You will not have any arthritis after you have a total knee replacement because it's all been replaced. This is what the implants look like, and the terminology for knee replacement is a little bit misleading. Hip replacements were done first, and with a hip replacement, you're actually replacing the ball, so we call it a hip replacement. And the terminology carried over to knees, we call it a knee replacement. I think a knee resurfacing is probably a more accurate term because the knee replacement replaces the cartilage. We're not just lobbing off big chunks of the knee and replacing it, but that's what it's called. So the implants, it's a cobalt chrome piece that goes on the end of the femur. Sometimes that's made of ceramic, and a cobalt chrome or titanium piece that makes up the tray that replaces the cartilage on the bottom half of your knee. And between that goes the plastic polyethylene piece. The other type of knee replacement is a partial knee replacement. And this is a knee replacement for someone who has arthritis isolated to just one part of their knee, just one side, whether it's the medial side or the lateral side or just under their kneecap. There's some real advantages to a partial knee replacement. I'd say these are my happiest knee replacement patients because a partial knee replacement tends to maintain normal knee motion. It feels like the knee you were born with. And that's because 2/3 of it is the knee you're born with that you were born with. And you've retained all your ligaments, so you have much more normal motion. The downside of the partial knee replacement is that it does have a higher failure rate. Not astronomically higher, but when we look at large groups of people, there's a higher amount of loosening of a partial knee replacement in the first year. And then if you look 10, 12, 15 years down the road, there's a higher risk of failure from the rest of the knee becoming arthritic. So that's kind of the Achilles heel, so to speak, of partial knee replacements. So what's new with knee replacement surgery are the new techniques, way of doing the surgery. We have new technology to put these implants in correctly. Initially, when knee replacement was first conceived and done, it was done using manual techniques or manual implants. And that's basically using rods and jigs to get the implant size and the positioning and the alignment of the leg. And the problem with doing it that way is that it can work very well, but it's not quite as precise as we would like, and it's not quite as reproducible as we'd like. So we have new technology, and that's computer navigation and now robotic assisted knee replacement. And these are related technologies. Computer navigation has come first, now robotics is coming in and kind of, it's just the next step beyond the navigation. So I'm going to explain to you how navigation works and a little bit about how robotics works. So with computer navigation, instead of using rods and jigs to get the alignment and the sizing of the knee, once the patient's in the operating room, pins are fixed to the thigh bone and to the shin bone, and points are registered around the knee, and that allows the computer to make a model of the knee, or it allows the computer to match the points you've registered to a CT scan of the knee that was taken before. Either way, you have the computer following that knee in real space, and you're able to fit the implants to the bone virtually. So you have a virtual model on the computer, and you're able to play with that, adjust the size, adjust the rotation, and on the computer get the exact fit you want. So it's a custom way of doing the knee replacement, whereas with the traditional knee replacement, you would make your first cut of the bone and cartilage and then start working backwards for sizing. So it's just a more precise way of doing the procedure. The navigation allows you to follow the knee in space, so you can look at your alignment before the surgery, during, and after, so to make sure that you're getting the leg straight and achieving what you want to do with the surgery. And it optimizes alignment, soft tissue balancing, and prosthesis fit. These are the keys to having a long-lasting knee replacement. Another nice thing about computer navigation and the robotics is that each cut that's made can then be verified. So if you think you're going to remove, 3 millimeters of bone, you make that cut, and you're able to check your cut and make sure that you didn't remove 2. You're doing exactly what you plan on doing through each step. With robotics, where robotics comes in is it's unfortunately, because it'd be a much better talk if the robot would like roll in the room and do the surgery, but that's not what it does. The robot controls the cutting device. So the surgeon is doing the cutting, but if you go to move beyond the parameters that you set, it's going to either stop the burr or the saw. So it's like an override. This is an example of a robotic handpiece that uses a burr. And it just shows how it works. So if you were removing the arthritic cartilage and you went to remove more, if you went to push that burr in deeper, the burr retracts. So it won't let you remove what you didn't plan on. Currently, that's what robotics entails, in its simplest form. It's navigation plus control over the cutting. This is definitely the way things are going. And I don't think it's going to go where we have robots actually doing the procedure. There was, believe it or not, a robot developed that you would set all the parameters and hit the button and it would make all the cuts for the knee replacement. And the FDA categorically said that is not ever going to be approved anytime soon. So this is what robotics is going to entail for orthopedics. So computer navigation and robotic guidance for knee replacement, this enhances surgeons' precision and reproducibility. It prevents unintentional removal of bone or cartilage, and it's accurate and reproducible. After a knee replacement, just like a hip replacement, typically one night in the hospital or home the same day if you're a candidate for outpatient surgery. Physical therapy starts in the hospital, and then you go home. Most patients are in outpatient physical therapy for 1 to 2 months after a knee replacement, which is a little different than a hip replacement. Most patients, it's very limited therapy afterwards. And just like a hip replacement, patients move from a walker to a cane to nothing. Most knee replacement patients are walking with a cane or nothing within 2 weeks. And driving, very similar to the hip replacement, 2.5 or 3 weeks before most patients are comfortable driving. In terms of activities after a knee replacement, very similar to a hip replacement, golfing and swimming are allowed about 6 to 12 weeks afterwards. Patients are advised not to do high impact things, just like that. Running and jumping is not recommended. So that's my talk. If there's any questions, I'd be happy to take them.
I heard there's going to be a version of Jiffy kit for the knee, sort of Jiffy knee option. Is that coming soon?
I don't think so, no. The problem with the knee is that, to get the exposure to do the surgery correctly, we don't have a back door or front door way of doing it like we do with the hip. So there are less invasive ways of opening the knee joint, and that's already being done. But there isn't anything on the horizon that I'm aware of. There have been things in the past where they've tried to do less exposure, like truly minimally invasive, tiny incision knee replacements. And it can be done, but the complication rate was unacceptably high because the implants weren't being put in proper alignment. And if you want it to last, that's the number one goal.
Is there a problem or are there problems with people who start with a partial and then come to need a full replacement? Does that work seamlessly or do you start over?
Well, it varies. That's a very good question. If you have a partial that goes bad and has to be converted to a total, what's that like? I think for patients, it's very similar to just having a total knee replacement. For the surgeon, it's a little more work. It's not quite the same thing. It's a little closer to a revision surgery than just a primary knee. But I think from the vast majority of patients, their perspective is that it would be very similar to just having a primary knee replacement.
Just follow on because you said the total was the gold standard and partial being indicated if there's only some deterioration. But can you sort of assume that you're going to continue to deteriorate and just go for the gold in the end?
Yeah, that's a good point. So the question was, if this gold standard is a total knee, where and when would you want to do a partial if you know that the rest of the knee could go bad? I think there's two circumstances where partial knee replacement makes a lot of sense, and that's in patients that are unusually young because the partial, if you can get them down the road another 15 years and then switch it to a total, that's a win. Or in older patients, if you have a healthy, 83-year-old who just has arthritis on one side of their knee, that's a much easier surgery, and the likelihood of that patient's knee wearing out is very low. I get nervous if I have a 62-year-old sitting in front of me with arthritis on one side of the knee, because I'm worried about the rest of the knee going south in the next, 5 or 10 years.
In your knee, you showed injection, cortisone, and then you had a couple other options down below. How do you know which to use? And is there a limit on how many of those shots you can get?
So when it comes to injections in the knee, I would typically start with cortisone because it's inexpensive and it typically works well. The gel shots come into the picture if the cortisone isn't working or it isn't lasting. With a cortisone shot, you can only get those at the most every 3 months. And typically they last a lot longer than that, or they're not working long enough to make it worth doing them again, as the arthritis progresses.
How long have you been doing the Jiffy hip, and where were you trained to do it?
So the Jiffy hip I've been doing since 2009. While I'm a fellowship trained joint replacement surgeon, when I did my fellowship, the Jiffy hip really was not a thing. So this is something I trained myself to do, which was, quite frankly, I think that's why not all surgeons do it, because it's technically difficult to learn. They say it has a high learning curve. That means it's hard to do right. So to learn that, I really traveled all over the country working with other surgeons. I did a lot of surgeries on cadavers before I started doing the surgery on my own patients.
Are there contraindications to the Jiffy hip, or do you always do that now?
Well, most patients are good candidates for the Jiffy hip. Contraindications there are. So, if you have hardware in your hip that needs to come out and it's going to have to come out through a lateral incision, it's usually not worth, making extra incisions. In patients that have a hip that's worn out and they need a revision, a lot of revisions, some revisions can be done through the anterior approach, but that's another scenario where that's not your go-to approach, and you're going to probably end up using a posterior approach. But for the vast majority of people having hip replacement, they're good candidates.
For hips and knees, both are considered highly successful outcomes. What would constitute an unsuccessful outcome in either of those surgeries?
Well, when we look at when I was quoting the survival numbers, those are knees that are still functioning. So they haven't loosened from the bone and been revised or become infected, or the patient hasn't fallen or broken the bone and knocked it loose. So that's really just, those numbers are based on survivorship and not function or satisfaction. And if you look at satisfaction, hip replacement patients typically are happier than knee replacement patients. Most patients that have a knee replacement will tell you, look, at the end of the day, I'm happy I did it. It doesn't hurt. I can walk all day long, and it's a lot better than it was. But I know this isn't my own knee. It doesn't feel like it. And that gets back to the complex motion of the knee. The hip, ball and socket, very simple, straightforward to reproduce. And your hip is really covered in muscle, which seems to protect it from stiffness like the knee might get. So hips do tend to do better.
What in your practice or at CarePlex, what percentage complications, I guess?
Well, in terms of major complications, very low, much lower than the national average or state average. In terms of primary hip and knee replacement, in the last 3 years, as far as I'm aware, and I'm the medical director at the hospital, there's only been one infection in the last 3 years, and that was a knee replacement. And that one, unfortunately, was a patient who had a cracked tooth, and the infection that showed up about 6 months after her surgery was from bacteria in her mouth. You know, and I think that's the big one, because infection is really the disaster. For things like blood clots, I think we're a little below the national average. And when you know, then it depends on what your definition of a complication is beyond that.
In full knee replacement, what's the percent of normal? Getting back to normal.
I think, do you mean like for patients, like how many patients get back to their normal activity level?
Mobility,
Yeah.
normal mobility.
Very high 90s. So, you know, and again, that's a loaded question. I think maybe a better way of putting it is that if you have severe arthritis and now you can't play golf, and you said, that's it, I'm done, I'm getting my knee replaced, you're going to be a lot more active than someone who gave up golfing 10 years ago and now can't go out to the mailbox to get the mail, and now they're going to have their knee replaced. You know, so your baseline activity is going to dictate how much activity, your general activity level a year or two afterwards.
In the UK, they're making research to replace the knee cartilage. I was just wondering if they were doing that type of research here.
Yes, that research is absolutely going on, and that, you know, that gets to the stem cells.
Yeah.
But currently, we don't have, you know, there's a lot of things we can't, that hopefully we'll be able to do with stem cells, like growing cartilage or growing hair. I'd be psyched.
Yeah, I think the stuff that they're trying to do is artificial. And if you had some cartilage, a little cartilage there, it joins up with it, and then you've got new cartilage. But I'm not quite sure of that.
There's plenty of centers working on that. That's definitely a topic of heavy research. I mean, there's going to be some heroes someday who figure that out, but currently we don't have anything that I'm aware of, and I haven't come across any, you know, literature showing anything, any way we have of really fixing arthritis with stem cells.
2 years ago, an orthopedic doctor was looking at my knee, giving me an injection, and I asked, should I stop walking because I'm trying to stay active? And his recommendation was walk as little as possible because you're going to be wearing that knee out. That's not true today, right? I mean, I'm hearing that it's better to have some silence.
It is, yeah, low impact. So for some patients, if your arthritis is severe, walking may be too aggravating, but, you know, stationary bike, weight machines, water aerobics, those are all things that are terrific for arthritis. So at some point, you know, walking maybe, because it's 3 times body weight each step, and that's semi-higher impact. So for some people, walking's too much.
Aside from causing pain, is there a downside to putting off surgery?
Yeah, so that's a great question. Is there a downside to putting off the surgery other than the pain? Well, kind of like I said before, if you let yourself become less and less active, having a hip or knee replacement, you're less likely to get back to the activity level that you had maybe 5 or 10 years ago. That's not necessarily a downside. It's a, you know, personal decision. But for most people, no, there's not. There are some instances where there's significant bone loss around the hip or knee, and waiting can, you know, make the surgery more difficult and the outcome poorer. But those are rare cases.
Do you or would you ever recommend a dual knee replacement?
What do you mean by
I've got
that?
2 bad knees.
Uh-huh.
Could they both be done at once?
Oh, yeah, there are some, yes, yeah. Both these can be done at the same time, under the right circumstances, absolutely, yeah. And I do that. You know, if you didn't need to, you probably wouldn't like it. I certainly wouldn't talk anyone into it because it's a much tougher recovery. But if I have someone who is, you know, really motivated to do it, has good reasons, you know, they're working, they only have so much time off, and they're healthy enough, absolutely, yeah, it can be done.
I think you mentioned that the cortisone shots last 3 months. Is that what you said?
Well, the cortisone shot may last a year or more. So the question was, how long will a cortisone shot last? It could last, a year or longer, and it may not work at all, and everything in between. But if you get one and it works really well and you want to do another one, the soonest you could get another cortisone shot in that joint is 3 months.
Does the body build up any kind of resistance to it, or is that not a...
No, that's a good question too. So the question was, do you become immune or do you build up a resistance to cortisone? You don't. The reason they stop working is the arthritis gets worse. So there's just more and more inflammation, and it doesn't keep the inflammation down as long.
Is there any age where surgery, when surgery is better? Just 50s, 60s? Is there any difference?
Yeah, so what's the ideal age for hip or knee replacement? Yeah, I mean, I think ideally 60s is probably ideal, but the largest growing segment of knee replacement is patients under the age of 60. I think as patients' attitudes have changed and surgeons are becoming more confident with how long these will last, we're seeing younger patients having hip and knee replacement.
How often it works that I have heard that surgery is just last option. Patients should try everything before decision about surgery is made. Do you think it works? For instance, stay active or just try with medicines, helping, or if at the end the patient will have worse and more complicated surgery after postponing this one?
So that's a good question. Again, kind of getting back to, can you wait too long to have the surgery if you're doing all these other things, non-operative treatment? I don't think that's the way it usually goes. It is important if you're having a lot of pain to have the joint checked out, get some x-rays and make sure there isn't, like a bone cyst or something unusual going on. Usually with arthritis, it gets plenty painful and disabling enough long before you're in a situation where you're really compromising the surgery. Sometimes. I used to do spinal anesthesia. The question was, do I do spinal anesthesia? And that ultimately is a decision made between the patient and the anesthesiologist. But generally, I don't. I usually do general anesthesia. And the reason for that is with the spinal, we don't have a short-acting spinal. So if you have a spinal anesthetic, you're not getting out of bed that day, which kind of goes against our whole philosophy with the healthy patient model. And it causes other problems, low blood pressure, urinary retention. So there are instances where that's the right way to go, but for most people, it ends up being a general anesthetic.
And also, one asked about customizing. I found that the parts you put in the knee previously customized and formulated, so the operator to fit that person's knee. Do that, or is that easier?
Well, so the question is, are there custom implants? Which there are. There's a couple of companies that will do a CT scan of your knee and make an implant to fit your knee, which is appealing and can work well. The downside of that, though, is if something goes wrong in that surgery, you don't have anything to fall back on. It's not a modular implant. So I prefer the computer navigation where, you're making a model of the knee on the computer and you're fitting it virtually. But there's a whole rainbow of sizes so that if you need to move up or down, you're not just walking in there with one implant.
You said your survival numbers are based upon old methods and old materials. How far back have you gone?
Well, most of the studies are you'll have like a 25-year. Every once in a while you'll see a 35-year, but the most common thing you'll see in the literature now are 20, 25-year survivorship studies.
So I had implants 7 years ago, so I'm on the new side, the old side.
You're on the new side. Yeah, you're in good shape. So the cutoff for that's a great question, because the plastics was changed the way that it's manufactured. The cutoff was right around the turn of the century, right around 2000. And the stuff that was used, the way the material was manufactured in the 90s, there was more problems with that. So I'm always a little careful with patients that have had a joint replacement in the 90s. I try to get x-rays more frequently to make sure they're not having excessive wear. Well, I'd like to thank everyone for coming out tonight. I'll be up here if you have more questions.